Welcome everybody to our webinar on accountable care organizations. We're going to be spending our time trying to focus not on the Medicare Shared Savings Program and all its rules and convoluted terms, but on what people are doing with ACOs that contract with commercial insurers primarily, or the strategy of using an ACO to work with commercial insurance. We're going to start that in just a minute. I have a couple of housekeeping items. You will have the opportunity to ask questions. Do use the chat box that I think will be readily evident. And then I would also like to invite everybody to join us again next month. Next month's webinar is going to be Wednesday, November 12th. They're always the second Wednesday in the month. And it's going to be tips for working with outside counsel on malpractice cases. And that'll be with John Kapuscinskis. John is a litigator that works in the healthcare area, has got a lot of experience working on malpractice defense and also on regulatory appeals and other sort of government cases. And he's got a lot of experience in malpractice cases, and we'll talk a little bit about what to do in working with the insurance company counsel and what to do if you are self-insured and want to run a malpractice defense on your own. So I think that'll be really interesting. John is a mesmerizing speaker, so it should be entertaining as well as interesting in 1 month. All right, so let's dig right into accountable care organizations. As I mentioned before, there are, in sort of common parlance, a couple of different approaches to ACOs, maybe a couple different ideas of what they are. The first is the ACOs that appear in the Medicare Shared Savings Program. And really the three-letter combination ACO is not much different from lots of the other three-letter combinations that have come out in past years, IPOs, IPAs, PHOs, and so on. Medicare Shared Savings Program came out with the idea that ACOs, accountable care organizations, were important, and it created one small, in effect, government product for ACOs to participate in, and then it worked hard to get a lot of governmental agencies to say, we're going to provide some regulatory space for people to operate these ACOs, even though they might otherwise implicate a variety of laws. So some people have said, let's look at this MSSP and decide whether or not we want to participate in it. And some have noticed that the MSSP is a very complex program, very expensive to participate in terms of all the work that you've got to do with the government, all the data, all the other information, and it doesn't produce a tremendously valuable additional reimbursement. So the Medicare Shared Savings Program is not necessarily terrifically attractive to folks that are interested in ACOs. Many of them say to themselves, well, I want to put together a network company, and the network company is going to try to really refocus the way we providers get paid in the marketplace. And the way it's going to do this primarily is by working with the commercial insurers. Now, some folks say we're going to be in both strategies. Some folks say we're going to have an ACO that works with Medicare under the MSSP, and it also works with the commercial insurers. So we'll talk a little bit about the MSSP, but really what we want to talk about is how to put together an organization that works on a more broad basis, and what are the rules that are going to sort of get in the way of that. I think that there's another kind of ACO that's sort of worth talking about. Some folks think that they'd like to develop an organization that will actually contract directly with employers or patients. And I think you'll get a flavor for the fact in this hour that that is a very big undertaking, a much bigger undertaking than the two sets of ideas that are right above with the bullet points. Really, what we're talking about primarily today is ACOs that are working with commercial insurance companies. So how do you set up an ACO, and what is it? Well, it's that box in the middle. That's this is a diagram that tells what 90% of ACOs look like if you put them on a chart and try to make a graphic out of it. I think it's important to say that this isn't the only design. You could get out your pencil and make a lot more boxes or a lot fewer boxes, but this is what the vast majority of folks look at. They say to themselves, okay, let's create a new entity, and that new entity will be almost every time owned by a combination of the hospital and the physician groups that are participating in, if there are independent physician groups. That box will work with the payers under contracts, and it will have subcontracts with a variety of participating providers, employed physicians, perhaps physicians that have a PSA with the hospital, and a network of physicians. So if you're looking at the elements of this thing, it's a box, it's a contract with the payers, and it's contractual relationships with the sub-providers. So in the process of developing an ACO, there is a lot of meetings that happen. And the meetings really have a number of goals that they're trying to achieve. One is to sort of design the business model for what the ACO is going to do. Second, to design the legal model for what it's going to do. And third, really to work with the lawyers to say, you know, what are we permitted to do? What are the boundaries of the behaviors that we can engage in this new delivery model? And if people have not gone through this process before, I think that what I've found is that it's a surprisingly long road. There are a lot of meetings that are quasi-negotiations about what sometimes seem to be small issues. And then there's a lot of work to try to get an understanding between the legal people and the business people about what is sort of the permitted zone of activity for the ACO. So what I'm going to try to do today, what we're going to try to do, is to give you a little bit of a roadmap to what will happen in those meetings and what kinds of issues you're going to be talking about in order to get to the end of this road. As I said before, it isn't very difficult to start out with the idea that we're going to create a box. And the first issue that you will have to deal with is to say, is this going to be a for-profit company or a non-profit company? For many, there isn't going to be a great deal of difference between a for-profit. Many people set up an ACO as an LLC, that's a for-profit LLC, or a non-profit. At this point, we're probably not talking about making a tax-exempt organization. We're really saying, is this thing going to have owners, or is it not going to have owners? And the difference is probably a small difference. It depends in part whether you're going to have substantial capital needs, and you're going to be wanting to look to owners to provide the capital, and are you going to have distributions that come out of the entity not as contract payments but as some kind of profits. Lots of folks go through this process and say, we really want to emphasize the idea that this is a conduit type of an entity. It's there to contract with the payers and to come up with an innovative way to distribute the money that we get from the payers to the providers, but it's not really there to make a profit itself. It's not there to be a profit taker in the stream. And so they say, we'd like it to be a nonprofit for that reason. Other folks sometimes say, well, look, even if we're not talking about making a profit, we really need to develop a significant business organization here. And that means we're going to have potentially care management services. We're going to have computer data processing services. We're going to try to understand population health management. All of that's going to require people. All of that's going to require capital. We need to have the participants in this thing keep track of what kind of contributions they're making and what benefits come from having made those contributions. And that fits the idea of a for-profit with shareholders better than the nonprofit does. That's really a conversation, and it's a conversation among the people who you have at the table participating in the development of this thing, and it's a conversation among the lawyers. I think if I'm trying to say what's the most frequent outcome, probably it is that we create an LLC. In some cases, a nonprofit is chosen, and I would say that by and large, the nonprofit is chosen when the model is a light model. It is providing very little in the way of real financial impact, and it doesn't have too much in the way of capital needs. Mentioned briefly, tax exempt or taxable as an option. It's very hard to be tax exempt as a network company. All those folks out there that are 501c3 hospitals get almost a free pass because promotion of health is considered to be a tax exempt charitable activity. But operating a network company is not generally considered that. So an ACO that is tax exempt probably has to have more activities than simply ACO activities in it. Doesn't mean that it's impossible, but most people are not going to choose an exempt entity to operate the ACO. So once you've chosen the kind of entity that you are going to set up, and let's pretend it's an LLC, the next thing that frequently happens is that you say, let's talk about what the governance will be. And a lot of questions immediately come up. Will there be some reserved powers that are given to the health system? And there are sort of a couple different levels of reserved powers. The first are sort of those generic big transaction reserve powers. The health system may want to approve board members. They may want to approve amendments to the governing documents. They may want to approve sale or merger transactions. It's also possible that the health system participating in the arrangement may want to have the right to approve any contracts with payers. They might want to have the right to approve who will be the new members of the organization. They may want to have the right to approve distribution mechanisms. They may want to have the right to approve the management. Who will be the CEO? Who will be the CFO? Will those folks have accountability only to the board of the ACO, which is a separate entity, or will they have accountability to the health system? Will they be, in fact, employed by the health system and leased to the ACO? All of those things I've seen, and it becomes a fairly deep conversation. In general, the guiding principle is that the hospital will desire greater reserve powers, greater sort of direct responsibility and authority with respect to the organization in proportion to, number one, how big its capital contributions will be, or its participation as a capital provider, and number two, what is the volume of its participation? So if the hospital envisions this as the way to house all of its third-party payer contracting activities and all of its care management activities and all of its sort of innovations in pricing, then it's going to say we can't join an organization that makes us a minority member on those things. If, on the other hand, it's got a number of different ways of participating in the provider-payer world, if it maintains much of the infrastructure that you need to do care management in-house and doesn't move it all to the ACO, then it might say, well, the ACO has governance authority over its activities, and we're still going to have the right and ability to participate in lots of other things. So you have quickly run through some of the key issues to setting up the organization. You've established the governance principles. You've created reserve powers to the extent that you need reserve powers. And then you sit down with the lawyers. Presumably you've already done that. And you've said, well, what are the limits to the activities that we can participate in? So what I said before was that the beginning part of this is easy, and that's really setting up the box, creating the box that I drew on that first slide. The second part of it, how to deal with all of these barriers to integration in ACO, is really a lot harder. And it's harder for a couple of reasons. Number one, here's this big list of laws that are the barriers to integration. And page 1 here are the federal laws. The antitrust law is a big deal. The anti-kickback statute and the Stark law, which of course we've dealt with in every other joint venture that we've put together, you know, those are actually in this case a little bit more easy to deal with. The civil monetary penalties law is something that you should be aware of, but probably isn't going to create a big problem. But the tax exemption rules also rather significant issue for people trying to put together an ACO, and they're really going to be worth talking about. And that's not all. Here's a whole bunch more just to make you sure that the lawyers are going to earn their keep. The state is going to have a whole lot of additional laws that you may have to worry about. These include potentially the insurance laws. Does somebody say you're an insurance company or need to be regulated as an insurance company if you're setting up an ACO? Managed care laws, that's a whole basket of related laws. They're like insurance company laws, and they regulate the people that are companies that are similar to insurance companies, managed care companies, utilization review companies, risk-taking companies, and the like. There are state anti-kickback laws, state Stark laws, state fee-splitting laws, state corporate practice of medicine laws, state antitrust laws, and state securities laws. All of these things can have an impact on the creation of the ACO, and we're not really going to talk about them today. We're going to go back and talk about the federal laws. You should be aware that in putting these things together, your lawyer is going to be worrying about all these other things too. We are going to talk about some of the state laws.
Yeah, a few of them.
All right, so let me start with antitrust. This is really one of the few federal or other laws that we deal with from time to time that is, if anything, more confusing and complicated than the Stark law. So those of you who've listened to us go on and on about the Stark law and really difficult webinars in the past that where you think that you've gotten turned around backwards and upside down, the antitrust law will do the same, really the same thing. A couple of kind of preliminary things I do want to say. Any ACO, especially an ACO in the purely commercial world, and especially one that maybe is pushing the envelope in terms of who's participating in it, has before it an analysis that's very complicated. It's a fact-driven analysis, and it's one that there's no easy answer to. And it's one that's based not on what the contracts say, but what you're actually doing. So when you get into this process and you ask the lawyer, is this okay, he's inevitably going to say, well, it depends on whether we do A or B. And the fact that we've created the organization with a certain kind of structure and certain contracts gets us a certain distance down the road, but doesn't answer the question ultimately, is there a risk that some antitrust regulator takes issue with what we're doing? Last thing, kind of from the 20,000 foot level, there's something called the rule of reason. And the rule of reason basically says that you can engage in this kind of an arrangement to the extent that it's reasonably necessary to accomplish pro-competitive benefits. That's a balancing test. And even after we've gone through all of the sort of precautionary steps, and even after we've attempted to get into the safety zones that the government has set up for antitrust, ultimately we're still going to have to ask ourselves the question, how would this balancing test be applied? And are we doing something that's reasonably necessary to accomplish the pro-competitive benefits that we're achieving? And that means, among other things, do we need all the people involved in this that we have involved? Do we need to have the contracting rules that we have set up? Do we need each of these details? Is it necessary, especially if it seems like it binds competitors together, is it necessary in order to accomplish the pro-competitive goal that we've set? Okay, that's all preamble to the antitrust rules. Let me give you a very short primer on this. In general, competitors are prohibited from getting together to do some specific things, among them, and maybe most important for this purpose, to set prices. Getting together to set prices with your competitors is a per se violation of the antitrust laws, meaning they don't have to analyze any further if they've decided that you are cooperating to set prices, if you are price fixing. There are a few other antitrust violations that are like this, that are per se violations, but let's not try to get into the weeds with those things. You start with the idea that getting together to set prices, which in some ways seems like one of the basic essential things that an ACO is doing when it's contracting with payers, is illegal. So, but here's the caveat. It's per se illegal to set prices, but if what you're doing is arguably not naked price fixing, you're really creating some new product that the marketplace, with all its separate competitors, cannot provide, then you're doing something that isn't prohibited as price fixing per se. Instead, it is analyzed under this rule of reason that I was describing before. It's a balancing test. In order to create this new product, this joint venture, this pro-competitive thing, do you have to get together with your competitors? If so, then it's okay to get together with the competitors for this pro-competitive purpose. So that's an idea that's existed in the antitrust laws for a long time, and it's been applied in lots of different industries and areas. Folks that are putting together organizations that are network organizations of the kind that we're talking about have looked at that joint venture idea and how it was applied in other places and said, well, that's really what we're doing. We're creating a new way to deliver healthcare services. It means that the hospital and the primary care doctors and the specialists are all talking to each other and saying, how can we best do our jobs and work together to maximize quality and minimize cost, to beat the other competitors in the marketplace. And we wanted to beat them both in quality and in price, and that means we're trying to integrate, and integration is sort of this key concept. So in 1996, the FTC looked at the healthcare industry and said there are lots of things that it would like to say about what's okay and what's not. And one of the things it said is, if physicians are putting together networks, we can define a safety zone for them. And the safety zone is that if you've got sufficient integration, either financial or clinical, and you're not too big, you don't take up too much of the market, maybe 30% of the market if you have a non-exclusive network, a lower amount if you've got an exclusive network, then we'll say you're in a safety zone, which means that the rule of reason applies. You still need to show that you are providing something that benefits the market, doesn't hurt the market, but the rule of reason applies, and you're probably going to be safe. That is a reflection of what the antitrust law outside of that safety zone had been anyway. When the government set up this idea of the Medicare Shared Savings Plan, it said to various regulators, tell people how much space they've got. And the FTC came out with a policy statement, and it said, if you are in the Medicare Shared Savings Program, then we think that you are putting together an organization that's intended to meet this joint venture exception. And as long as you are doing that, we think the rule of reason applies. It's not a per se violation. And we'll create another safety zone. And this safety zone was a little more detailed, and it was a little broader. It included not just physicians who are creating network companies, but other kinds of providers. And it says, well, if you've got 30% or less of each of the common services in the PSA, and that PSA, that's the primary service area of all the people who are participating in the ACO. It's the counties where they have 75% of their patients. And if you're non-exclusive with regard to all hospitals, meaning that the participants can contract with payers, and if you meet some other special rules, we will say that the rule of reason applies, and you're almost certain to be okay under the rule of reason. And then they said, there are several other things that we want you to know if you're putting this thing together. There's some conduct that you need to avoid. Number one, you need to avoid sharing price information. Number two, you need to avoid working with the payers and eliminating from their ability to steer patients. We don't want you to put anti-steering language into your contracts, the contracts that you're sharing with the other people in the ACO. We want you to avoid tying arrangements. If you buy service A, you've got to buy service B. We want to have you avoid exclusive network contracting with your sub-providers. And we want you to avoid contracting in a way that restricts the information sharing that would otherwise be permissible with the buyers, including the patients. So those were all very interesting statements that came out of the FTC and tell us a little bit about how to set these things up to avoid the antitrust rules. If you were to go back and summarize this, you would say a bunch of principles apply. Number one, you're going to have to take a look at how much market power the participants in your network have. If they get up over 30%, you're probably not in a safety zone. That doesn't mean that you're doing something that's illegal. It just means that you're not going to be able to point to that and say, I'm protected by the safety zone. Number two, you're probably going to want to expect that you're going to have a non-exclusive network. That means you're going to go contract with a payer on behalf of Clinic A, but Clinic A still has the ability to go contract with that payer independently or contract through some other network. Non-exclusivity is the place that almost all of these organizations end when they're analyzing this question, how to deal with the antitrust laws. Third, you need to have a level of integration that makes your offering in the marketplace something that's truly new. And this is an interesting point because for many people, clinical integration is difficult and is achieved over a long period of time. Financial integration is something that you get by participating in a particular kind of risk contract with the payer. If you're sharing risk with the other people in your network, you arguably are financially integrated. And as I'm going to mention in a minute, the more risk you're sharing, the better that is on the good side of the balancing test. We're really doing something new in the marketplace. But it also puts a negative on the balancing test because the more integrated you are, the more you are empowered to really negotiate the full price that payers are paying. So I want to bring this down to what kinds of risk arrangements or integration, financial integration arrangements, ACOs may work with payers to create. And you see two or three things that are in the minds of most people that are putting these things together. The first is shared savings. This is really what the MSSP program starts with, and people are getting to be pretty comfortable understanding how shared savings programs work. Basically, what they say is we will define a total cost of care target for a particular population of patients. We'll try to figure out what that patient population is, assign it to this network that's being created under this contract, and we'll have a contract with the payer that says, well, all the individual providers will keep their basic fee-for-service contracts, but if, as a group, we beat the total cost of care target, we'll get an additional incentive payment. That'll be paid to our ACO, and then the ACO will distribute that on down to somebody below. And if you look at that and say, well, let's apply this antitrust balancing test, what you find to start with is that the basic price setting for the basic service that is being provided by the different participants isn't being jointly negotiated. The only thing that's being jointly negotiated is the incentive payment around total cost of care incentive. And so the antitrust harm of people coming together to enter into that kind of arrangement is a lot less than it would be if what we were doing is really getting together to say, here's my base price. So if we're saying what is the kind of organization that's necessary to accomplish the pro-competitive benefit, well, here the pro-competitive benefit is we're offering to the to the marketplace an incentive, a group that's willing to go on an incentive basis to try to reduce the cost of care. That seems like it's a great pro-competitive benefit, and all we're doing on the negative side is we are getting together to enter into that arrangement. People who are putting together ACOs also sometimes think, well, really we want to go beyond total cost of care incentives and really negotiate a full capitation. The thing that's worth noticing here is that full capitation means that you're negotiating the full price for everybody that's in the network. If there's no limit on the risk, up or down risk that comes with the capitation, then really capitation substitutes for the price that the individual clinics or hospitals or other providers are charging, and that means that the pro-competitive benefit may be bigger, but the anti-competitive nature of that negotiation is also bigger. It's harder to get to capitation, and it's harder to get your lawyers to be comfortable with it. And if you start out with an ACO that is doing total cost of care and there's a comfort level that's reasonably high that that's okay, that doesn't mean that capitation will be okay. A third idea is bundled payments. That's where folks say, well, let's take a limited set of patients or cases like an OB bundle for a delivery or a total joint, and we'll get all the payers, all the providers that work on that piece of work or that encounter to create a special price. That's kind of in between shared savings and capitation. It's only a small part of each provider's basic set of services, and it doesn't really replace their fee-for-service, but on the other hand, it might replace it for that particular kind of encounter. So anybody that's looking at this from an antitrust perspective should go a lot farther than just saying, how close or far are we from the safety zones? You're going to need to apply the balancing tests and say, what are you doing? What are we doing with the regard to contracting? Does it look like something that we can support if we get asked the question, why did you have to get together with these payers, with these providers, in order to offer this service to the payers? All right, so I'm going to talk a little bit, and it's going to be quick, about anti-kickback and Stark. In the anti-kickback context, what you're really mostly worried about is whether there is a payment between providers who are referring to each other. And if we've got everybody together in an ACO, that's going to mean, did we decide on distributions, and the decision to make distributions in a certain way is intended to induce referrals? Or, when we set this thing up, did we take over some of the administrative expenses that our referring provider might otherwise have and bankroll them someplace else? For anti-kickback, those are very familiar questions for your lawyer to analyze. Intent is the key issue, and as long as payments are fair market value, they're in proportion, and you're not taking on somebody else's costs, you're probably okay. Stark has in its many sets of exceptions an exception for risk sharing, which is a very broad exception. It broadly protects payments that are related to some kind of insurance enrollees, including hospital or PHO payments downstream to physicians that are done on a risk-sharing basis through some kind of network. It's almost certain that that Stark exception will cover almost everything that you do in an ACO in terms of distributions. So that leaves as the only real key Stark question whether the hospital is taking on somebody else's expenses. You should be aware, and your lawyers will know, that there's also a civil money penalty law that prohibits payments to a physician to reduce or limit services. Most likely that's not going to become a big issue for your ACO. Also worthwhile to understand that nonprofit entities are not allowed to distribute profits to their members. We mentioned that before when we were talking about what choice of entity we have. I want to talk a little bit about tax exemption. Most hospitals are tax exempt. That means that several things. Number one, they're not supposed to have a substantial part of their activities be non-exempt activities. They're not supposed to give their insiders or private individuals excess payments, unreasonable payments, or engage in excess benefits transactions. They will also be somewhat concerned about being taxed by the government for unrelated business income, which is really essentially non-charitable activities that they're engaged in that are profitable. And they'll also be a little bit concerned about whether joint venture rules that govern nonprofits working with for-profits will apply to sort of restrict what they're doing in the ACO context. By and large, there are a few things that will make every issue under tax exemption go away or be easy to deal with. Number one, the exempt organization is going to have to get control of the organization that's in proportion to its contribution. It's going to have returns on its investment that are in proportion to its contribution. It's going to have the organization, if it's really engaged in commercial activities, not be so big that it is a substantial part of its overall activities. And it's going to have payments that are payments out to the physicians, either directly or through the ACO, be reasonable, be fair market value, and be proportionate to the activities and responsibilities taken on by both parties. So I'm going to talk really briefly about how ACOs can pay. And there are a number of ways that they typically pay. There's often a payment from an ACO for a variety of services that are provided by the people who are serving the organization. So whoever is providing care management services, administrative services, IT services, sometimes that comes from an outside provider. Those are going to have to be set out in contracts. They're going to have to be fair market value, and there's going to have to be some way that the internal costs of the ACO are covered by the ACO, and it's got to not be simply that the hospital bankrolls it. Then there are all kinds of ways that the ACO may pay out incentives, and the key to all of this, from a tax exemption, Stark, fraud and abuse, and every other perspective, is proportionality, fairness, and fair market value. A bunch of legal issues implicated by distributions. We've talked about them a little bit already. There's a third part of this, and we've sort of set up the organization and talked about the scope of its activities. The other thing that we really need to do is create the contract relationships that we will have with the sub-providers. And Lori's going to talk about that and also about some state laws that have particular relevance to those contracts.
All right, thanks, Steve. Steve mentioned that we weren't going to really hit on much of the state regulation, types of regulations that can get in the way, or at least make life a little more challenging in setting up and running your ACO. One that we are going to spend quite a bit of the remaining time on are state insurance laws and related laws, because they can really impact the kinds of relationships the ACO can have, or the format in which it's permitted to engage in certain types of activities, and some related managed care and risk-bearing entity type laws. And then kind of once I'm through that piece of it, we'll probably have a little bit of time, and I'm going to quickly go through the second thing Steve mentioned, which is the relationships that the network has with its providers. If you think back to Steve's drawing or diagram, there are the employed physicians and then potentially independent entities or non-employed physician entities, and possibly other types of service providers, and that's going to be one of the questions the ACO has to grapple with. So as we look first here at the insurance laws, the ACO is going to have to figure out if it might be engaged in the business of insurance. And this is going to be defined typically in state statute, and the actual meaning of what it is to be in the business of insurance is then kind of parsed out by the courts. There might be attorney general statements on this. There might be state agency communications, either from the Department of Insurance or Commerce or whomever regulates the various insuring entities. If it turns out that the ACO is engaging in something that constitutes insurance, I'll talk about that a little more in a second, then of course they would presumably, unless there's a reason that they wouldn't be subject to all of those requirements, would need to be licensed as an acceptable type of insurance entity, and there's a big downstream exception that we'll talk about on the next slide. So if the ACO is not engaging in behavior that involves the allocation or the assumption of risk, then it probably doesn't need to worry about this question. So if you have an upside-only shared savings, a bonus-type program on top of a market-based fee-for-service arrangement, you don't need to worry about this. And then kind of going to the other end of the risk spectrum, if the ACO is going to try to undertake global capitation arrangements or other arrangements that, in essence, pool patients as a means of managing risk, so, percent of premium or some other form of per capita payment over a population, then that is going to fall within the definition of insurance. When the courts evaluate this, they look to see is the purpose or the core of the arrangement intended as something that is involving the allocation or the assumption of risk, or, on the other hand, is it really a contract for the provision of services? And so at the other end of the spectrum, you're going to have things like the bundled payment that Steve was talking about, where it's payment for a specific episode of care. DRG is an easy example, a case rate, something like that. That is not going to be found to be insurance. But a lot of the other creative and innovative arrangements that are coming up are going to fall somewhere in the middle of this spectrum. It's going to be less clear, and there will have to be an analysis under the state's particular definition of insurance and an evaluation of whether the risk that is being transferred, assuming there's risk being transferred, if that is sufficient to constitute insurance risk. Going to the next slide there. So the good news is that in many states, and I'll say many states but not all states, the regulators do not regulate so-called downstream risk arrangements. And this is where a provider organization assumes risk from a licensed insurance carrier, an HMO. And this is on the theory, I think, from the regulator's perspective, that the agency already has jurisdiction over the regulated entity, and the regulated entity is ultimately on the hook for ensuring that the beneficiaries or the insureds have access to appropriate levels of services, that ultimately the coverage promises are fulfilled, for things that are covered under the person's benefit plan. And so in those cases, in those states that permit, again, downstream risk arrangements without regulating the provider organization, that probably works. So that said, some provider organizations in some states are regulated as risk-bearing entities. And this is even if the risk is assumed downstream from a regulated entity. And then under these laws, there might be a requirement to seek a certain type of licensure, usually less onerous than a full insurance license, maybe certification, some sort of registration, possibly reporting obligations. Massachusetts is an example. I'm not going to go into much specific state stuff here, but just to kind of give you a flavor for it, Massachusetts has a registration requirement for risk-bearing provider organizations. And these are any organization, a provider organization that enters into a contract where the payment methodology under the contract creates a downside risk. And then they kind of define this, and they exclude from downside risk things like DRG payments and per diems, and bundled payments. So along with that comes an application process and solvency certifications and kind of more in the vein of what the insurance regulators are typically doing, is making sure that consumers are protected. California is another example. If you take global capitation for physician and hospital services, you'll need a limited insurance or a limited Knox-Keene license. And if you're taking capitation, if physicians are taking capitation for the services that they provide, limited to the services they provide, then there is there are Department of Managed Health requirements related to financial solvency. So, short of it is, it's really important to look at the state laws that are going to apply in the context of assuming risk, and figure out if how you can comply with them if that's the model that your ACO is going to follow, or what you would have to do to get out of them if you don't want to go down that path. Some of the other places you would need to look into this specifically would be New Jersey, New York, kind of usual suspects, Ohio, Pennsylvania, Colorado, Oregon, Illinois. I know there are examples of those. You know, again, if and when they apply is going to depend a lot on the specific ACO, how it's set up, and what kind of contracts it's entering into. Finally, also keep in mind that if the ACO is going to contract directly with consumers or directly with self-funded ERISA-governed plans, then the state agency is almost certainly going to require that you be a full-blown insurer of some sort. Those arrangements don't typically get the benefit of any of these lesser regulations for risk-bearing entities. So it's, you know, if you decide to go down in this last bullet here the route of becoming an insurer, it's a huge undertaking. It's going to add a lot more expense. It's going to add a bunch of compliance activity. But it also may open up, depending on your kind of the ACO's longer range plans, some significant new opportunities for the ACO to expand what it does, what its offerings are, to be able to compete with payers rather than relying on them for access to patients. But I think in these early stages, I think ACOs look a lot to the insurance companies to provide a lot of the infrastructure and the data crunching and analysis that maybe the ACOs can't as easily tap into. Okay. We kind of covered most of this. Again, it's going to depend where the ACO operates, but I just want to point out, if you have an ACO that's operating in multiple states, depending on what those states are, the challenges could be very, very high, and it could be very complex to make the arrangement work. We kind of talked through this, so I'm going to skip over it, but again, type of payment, the scope of services, all of that is going to roll into your analysis of whether or not the ACO is engaged in the business of insurance. And then following on the same theme, we talked just briefly a second ago about ACOs that choose to follow the insurance laws. In some states, you may not have a choice depending on what types of arrangements you're entering into. But then in those states that permit the downstream risk arrangements, you could decide that you're just going to always contract as a downstream entity from a regulated insurer of some sort. Again, beware of other state laws that aren't specifically insurance laws, but that regulate risk-bearing entities. And then finally, in this same theme, are there other state regulations that may apply? And the answer is always, of course there are. If the ACO is not licensed as an insurance company or an HMO and is taking on as a delegated function things like claims processing, you may need to get a third-party administrator license. Steve mentioned possibly there's some utilization review or those kinds of things going on. If you're doing that on behalf of a plan or in a way that meets the state requirements, you may need a utilization review organization license. And then there are some other laws that are out there that regulate networks and whether networks can contract as an intermediary between a physician organization or between healthcare providers and licensed insurance companies those regulations may also apply and may actually influence the structure of the ACO and have registration or other requirements. And finally, it's important to understand that states are also thinking about having ACO-specific laws. New York is an example of a state that came out last year with ACO regulations, and parts of the regulations deal with Medicare ACOs, part I think deal with the Medicaid managed ACOs, and then commercial ACOs. And under those regulations, the way they define it is pretty typical of kind of what we think of as an ACO, clinically integrated with providers coordinating to provide care to a defined population, and they share some sort of governance. They negotiate and distribute payments, and they take accountability on for quality, cost, and delivery of care. So under those regulations, there's a certificate of authority requirement, and you have to meet certain requirements around the organizational structure and competencies. So again, really important to understand the state requirements around insurance, and then again these sort of related to insurance managed care ACO type requirements. So in the few minutes that remain, and kind of sticking with the theme that we've been on during this talk today, relating to what are the regulatory issues that come up for ACOs, kind of what's going to make you have to have a conversation with your legal counsel, what is going to make the lawyers nervous. I'm not going to go through the remainder of kind of the next 8 or 9 slides here one at a time, but they're divided into two sections. One is the ACO Participation Agreements, which are the downstream kind of network agreements with providers that will be subject to the ACO payer agreements. And then after kind of 4 slides, there's a few slides on kind of the content of the payer agreements. And we could talk for hours on the details that go into these types of agreements, but I want to kind of just set them out in a 6 or 7 high-level themes. One, you probably already know just from being in this industry, these are, and from Steve's what Steve was saying, these are extremely complex relationships, and the new and the creative and the innovative things that are happening are all very exciting, but it takes time to think through what the details are, to make choices, to make sometimes what you think are going to be easy choices become hard choices, and then to create the appropriate alignment between the various parties and the interests and the incentives that are in play. Kind of the second theme is that and you'll see this from if you've read through or when you read through the participation agreement slides and the payer agreement slides, there's a huge parallel, and necessarily the provider agreements and the payer agreements really do need to work together. And so there's a little bit in the beginning of a chicken and egg problem, and I think that's a very big reason why we see a lot of provider agreements that are quite vague. And they say, you're going to be in our network, you're going to see the people that we say are assigned to us, and we're going to pay you something, and we might tell you what that is at some point down the road, and you're going to be bound to all of our payer agreements. That's one way to do it. I personally prefer taking the time and some effort to try to get to a little bit more transparency around what those things are. And then obviously there's a whole other piece of the provider network arrangement that is going to defer to clinical policies and protocols and expectations, complying with performance measures and all of those things. But kind of big picture, make sure the provider agreements work with the payer agreements and vice versa. The third kind of big giant theme is data. Given how data heavy these arrangements are, the parties really need to understand what data is going to be shared, with whom, how, when, what quantities, what platforms, and then if there's going to be a bunch of practical elements that need to be figured out. If, for example, quality performance is going to be based on claims data, then is the payer going to provide interim reports on that? Are you going to be measuring it as the ACO? How are the ACO providers going to be able to gauge performance during the program year? So it's not a big surprise at the end, because that's not really consistent with the whole purpose of these entities and these programs. Who pays for what? There may be some anti-kickback questions that come up when you're talking about electronic records and systems and stuff. But in getting back to the regulatory piece of it, once you know what the expected backdrop is, you're going to have to figure out and make sure that everybody can comply with the HIPAA requirements. In all likelihood, there's going to be a web of business associate agreements that need to be put in place. These are going to permit the data sharing, and then the parties are going to have to be sure that they have a mechanism for limiting shared information to the minimum necessary, that the data sharing purposes can occur, usually under HIPAA without a HIPAA compliant authorization, as long as they're for permitted purposes, which are treatment, payment, and appropriate types of healthcare operations. And then maybe a bigger challenge is going to be figuring out under state law, what do we need to do? What kinds of consents need to be obtained and need to be in place? What do they need to say? What do patients need to agree to so that data can be shared with the ACO, with the payers, and among the ACO participants? So that'll be that's a big compliance area that needs to be figured out. I will say also, frequently the payers are going to put the burden of getting the consents on the ACO, which means the ACO is going to need to make sure that the ACO providers are getting the appropriate consents. And again, it's just an important detail that will need to be carefully thought through so that those processes are in place to get the consents put into place. And also for those patients, depending on what your attribution methodology is, if you're not seeing the patient, but they're attributed to you, then you're going to have to work it out with the payer, whether the payer has the ability to share that kind of information or is getting a consent that permits that. The next kind of fourth theme here is around compensation. I realize we're getting very close to the top of the hour. But Steve discussed some of the legal issues around payment to the providers in the network. You're also then going to have to figure out and get down to a level of detail that everyone understands around how the ACOs are being paid by the payers. And again, back to that insurance question, are you triggering any state law requirements that you either do need to comply with or figure out how to do something different so that you can avoid them? Another couple of things just in connection with payment. If you are, if the ACO is has an arrangement with a payer where the payer's Medicaid, managed care, or Medicare Advantage enrollees are in the mix, it may come up that you'll have to worry about compliance with the federal physician incentive plan rules. And so that can layer on another level of compliance effort, possibly expense, depending on if you have to put PIP levels of stop-loss insurance in place and comply with the other requirements of that. A cap is the other way to deal with that, where you can just cap payments to providers. But again, depending on what place in the spectrum of risk taking you're on, that's not going to work at the extreme end. And then also, again, state law is possibly going to have requirements around the types of incentives that are forbidden to be offered by, for example, an insurance company. Usually it's consistent more with, Steve mentioned, the civil monetary penalties, prohibitions, and it's going to be really paying for flat out, reductions in services, number of services denied, referrals that have not been authorized. So you can't do payments for that. Again, probably unlikely it's being presented that way in an agreement. And then fifth theme is going to be around exclusivity. Who's in the ACO, who's participating through the payer agreements. There's going to be, again, antitrust considerations that come up around this. If you're including the hospitals in the ACO arrangements, that's going to kind of forge into some newer territory in the antitrust analysis. And then, are there any state law limitations on the ability of the ACO to restrict a provider's ability or right to provide health care services or procedures to another group of providers or to a health plan? And then also there might be some competition provisions put into the payer agreements where either the payer is requesting protections against the ACO competing with the payer, or the ACO is seeking protections against the payer competing with the ACO. And again, you're going to have to worry about, are we venturing into territory that puts us at risk of allegations of illegal restraints of trade, group boycotts, tying arrangements, any kind of market divisions. And then finally, and I know I'm just kind of skipping from topic to topic here, are the payers going to need to address any, in terms of if they want to set up a narrow network or an exclusive network, do they have to deal with any willing provider laws or possibly essential community provider contracting requirements? And then the last thing I was just going to kind of leave you with is because of the complexity here and because of the newness and the innovation, there's a much higher risk than when you're used to working with templates that there are going to be gaps. So it's going to be important as you draft these things, as you think through all the details, identify and avoid big gaps that, kind of try to answer the what ifs. What if the agreement with the payer terminates mid-course? What happens? How does the shared savings work? How do we do a settlement? How do we, are the performance measures going to lend themselves to a mid-year evaluation, or does that just not work? So with that, I will turn it over to Steve for just a couple final comments.
And there won't be very much. I'm going to say we're done. And tune in next month for John Kapuscinskis, who will give a scintillating talk about working with outside counsel on malpractice cases. I was talking to him. He was right next door to my office, and he did scintillate a couple times this morning. So that's the second Wednesday in November 12th. Thanks a lot.